It is now time, though, for our next two sessions. So stay here for the discussion panel on digital health and then switch to the live deep dive session channel on the platform session organised by Pfizer on breast cancer policy scorecards, Latin America Joint Initiative Model Project. Now, for both sessions, participants can, of course, ask questions to the speakers using the live question chat box. You will not miss anything, as all the summit sessions are, of course, available on demand within a few hours' time in the digital library of the summit platform. So, over to our next summit discussion panel, Digital Health to Drive Equity. How are digital solutions transforming the delivery of care? Now, in this panel, we will hear examples from those working in the digital space on how they've addressed challenges in the delivery of cancer services. Before we welcome our three panellists, I would like to, of course, invite our virtual audience to send their questions through the live question tab. And let me now introduce our three panellists for this session. Dr. David Klimstra is Chief Medical Officer of Paige, Dr. Sanjeev Arora, Founder and Director of Project ECHO, and Dr. François Uwinkindi is Non-Communicable Diseases Division Manager at the Rwanda Biomedical Centre in Rwanda. Welcome to all three of you. Dr. Klimstra, if I can come to you first. You've been working for more than 17 years, I understand, in sort of digital solutions, prototyping, developing, bringing to market some of the most advanced machine learning as well. So many companies now are starting to use AI, artificial intelligence, and trying to apply that in the diagnostic space. So what do you think will be the most disruptive innovation in applying AI when it comes to cancer?
Well, thanks very much for the question. There are several different aspects that we can look at. First of all is how do we get the most data, the most use out of the data that we're generating. Cancer medicine has moved towards larger and larger data sets, everything from genomic sequencing, proteomics, and the digital environment also generates enormous volumes of data that can now be analyzed computationally and ultimately integrated so that we can take the best advantage of the information we're collecting and better inform treatment. There's also the aspect of access, which a digital environment enables greater access, and artificial intelligence enables greater access in areas where cancer care may not be at its optimal level. And so I think that also has the potential to hugely disrupt cancer care throughout the world.
David, talk to us a bit about deep learning. What does this mean in relation to improving the early detection of cancer?
Yes, well, deep learning or machine learning, artificial intelligence basically enables in the computer vision arena, which Paige is a company working towards pathology artificial intelligence, in which the computers actually learns how to interpret the images that now are interpreted by pathologists. And so this basically teaches the computer how to recognize cancer, or even better, how to understand aspects of cancer biology based on simple input images, routinely stained pathology slides. And this, again, enables us to derive more information from the pathology slides and to do it without the need potentially for expensive and sophisticated other testing modalities.
Just hearing you talk about artificial intelligence, it's really obvious that AI in health has the ability to improve services in high-income countries, possibly reduce costs in lower middle-income countries, and even potentially provide life-saving systems where perhaps nothing currently exists at the moment. Are we ethically, are we morally obliged to deliver technologies like artificial intelligence, or should it be driven just purely by money, commercial markets?
Well, I mean, I think one of the beautiful things about this is that once you've developed the technology, which, don't get me wrong, it is an enormous amount of research and testing to produce valid AI models. But once you have developed it, it can be deployed very simply in any market. And so I completely agree that this is an ideal opportunity to improve pathology care throughout the world by employing technologies that are adapted to work with the most simple of preparations. So the simple answer is yes, absolutely.
Are there some reservations that some people might have with regards to AI? And if they are, what are they, and how would you address those reservations?
Oh, yes. Well, I mean, we use AI every day, of course, and many people aren't even aware of how much of the interactions they have with their, computer and other electronics are driven by AI. In the radiology field, there are many FDA-approved AI algorithms in play. But when you're used to doing things in a certain manner, any change is disruptive. And putting your trust in a computer to provide information that you can't perhaps understand how that was generated is a little off-putting for people. And so I think it's very important to produce high quality AI that's rigorously validated, approved by regulatory bodies, et cetera, so people develop a level of comfort and confidence in using it.
Okay, David, stand by, because we'd like you to stick around for the Q&A that's going to come at the end of the session, but I just want to get to some other panelists as well. And we'll move to Project Echo and speak to Dr. Sanjeev Arora, who is the founder and director of Project Echo. Wonderful to see you, sir. Thank you very much for being here at the World Cancer Congress. Now, at the Cancer Congress, sorry, we're at the World Cancer Leaders Summit, but at the Cancer Congress in Kuala Lumpur 2018, I understand that you shared with all the participants there the story of Project Echo and the fact that it started with hepatitis C in rural areas of the United States. Now, over the years, this model has expanded, right? So Project Echoes are now focusing on many, many different topics related to healthcare. So talk to us about how many Project Echoes there are currently focusing specifically on cancer.
Hannah, thank you for that question. So when I was in Malaysia, we had about 100,000 learners in 50 countries that were healthcare professionals being mentored on Echo. We've experienced massive growth such that in the first 9 months of 2021 alone, more than 1 million participants in 180 countries have been mentored on Echo. We have hubs overall in more than 600 organizations like the National Cancer Institute in Washington, or Center for Disease Control, American Cancer Society, etc. But I think, and for cancer alone, we have 91 sort of academic hubs, and they run about 170 networks. But really the more important question here is why? Why are we doing this? And the fundamental reason is that we see Echo as a way to reduce disparities for cancer care. We know that a child in Africa with cancer has only a 25% chance of surviving versus 80% in the United States. Similarly, breast cancer rates and outcomes in Pakistan or India or Africa, many more deaths. And so one could say that if they had enough money, if they had more oncologists, if they had more medicines, etc., cancer care would improve. But we are asking a different question. We are saying, what can we do today, right now, to improve outcomes, reduce disparities? And so we work across the entire continuum of cancer care. And the answer to the question we found is we can improve prevention of cancer, smoking cessation, HPV vaccination now. We can improve colorectal cancer screening, breast cancer screening now. We can improve cancer treatments, diagnosis now, palliative care, survivorship. So Echo is saying that while we wait for more equity in money in cancer centers, et cetera, why not start with a workforce training and mentoring model so that we can reduce disparities today? And that's our goal, and that's what we work on in Cancer Echoes. And we've trained tens of thousands of healthcare professionals in these countries where we work.
And so that's fascinating. So that's how the Echoes work that's how the work is manifests in the training and actually the upskilling of a workforce as well, and mentoring programs. Fascinating stuff. Now, obviously, for many of us during the COVID-19 pandemic, everything sort of turned virtual, didn't it? Including this summit as well. Everything went online. In what way is Project Echo different from a standard webinar mentoring thing, an invitation that we get, every single week into our inbox? What's different about Project Echo? What's unique about it?
Yeah, what a webinar does, Hannah, is there's expert knowledge, and we sort of go around, fly around, and spray it into a country or for healthcare professionals. It's a little bit, healthcare is much more complicated. Let's take a cancer example. Let's say we have an expert in cancer, breast cancer treatment, and we start an echo in it, and we have, let's say, 25 healthcare providers from Sudan that are being mentored in treatment for breast cancer. Now, what's going to happen is the best practice protocol may say you need to use drug A or drug B. The best practice protocol may say after 3 months of treatment, you do an MRI scan. But in that place where this doctor is treating breast cancer, there is no MRI scan. And drug A and B are not available, but C is available. Now, we may not be able to get an 80% cure rate on C, with C, as we would get with drug A and B. But what ECHO will do is, by creating a community of practice of these 25 people in Sudan with the expert, where they will customize this treatment to the need of a patient in Sudan. So it's about a mass customization. What is the best we can do in those circumstances today? That's the goal of ECHO. And that process, in one echo, let's say it's lasting 90 minutes, we may discuss 8 breast cancer patients in Sudan, treat them all with the best we have, making sure the perfect is not the enemy of the good here. But more importantly, these doctors and nurses in Sudan will learn about how to treat breast cancer to the best of their ability in Sudan with mentorship, but they learn from each other, which is what we call all teach, all learn. So that's very different from a webinar where I have a person from the National Cancer Institute in the United States giving a lecture on how to treat breast cancer. That's just like trying to teach your daughter to drive a car by giving her lectures on how to drive a car. And Hannah, I don't know if you ever done that for your son or daughter.
He's 2, so no, not yet.
What we do is we do guided practice. We sit next to them and say, hey, let's drive. I'll tell you how to do it.
Yeah.
When we had difficulty, we'll give you feedback.
Yes,
That's
exactly.
ECHO.
That's the way you do it. And I love the analogy that you gave there of the perfect being the enemy of the good. And the fact that you take what's available to you and you make that an efficient process as well. It makes so much sense as well. And thank you for the analogies in bringing it to life as well. Where do you see Project ECHO going then in the future? How do you see it evolving?
I think one of the biggest problems, Hannah, we've seen in the world is with the COVID-19 pandemic. Huge problems have occurred in multiple diseases areas. Patients all over the world in tuberculosis didn't receive the right treatment. The World Health Organization recently did a survey of almost 100 countries and found that for many diseases, including cancer, 50% of the people didn't get the appropriate prevention services, screening services, diagnostics, etc. We made a lot of progress with science in COVID-19. We developed vaccines, etc., quickly, but we got completely left behind on cancer diagnosis, etc. So there is a tremendous amount of catch up to do on these patients. Otherwise, we will experience hundreds of thousands of excess deaths in the world. So our focus right now is how do we strengthen health systems so that they can catch up in the post-pandemic world to make up for all this lost time with delayed diagnosis of so many critical diseases which can be fatal for patients.
Sanjeev, why is it, though, that cancer has suffered so much in the aftermath of this pandemic? Why is it that so much time has been lost? Why this disease and not another one?
Hannah, what happened is that, most of the low-income countries in the world, the real important way to save lives in cancer is twofold. Make an early diagnosis. And that involves teaching people about a disease, of course, to teach them how to prevent it, but also bringing them in for what we call elective procedures. What does that mean? Mammography, an annual breast exam, cervical cancer screening, with a pap smear, and many others of this nature, coming for a colonoscopy or a stool blood test to diagnose colorectal cancer at a treatable stage, and then doing surgery if required. All these things were completely postponed. Most low-income countries didn't even have masks available in the first parts of the pandemic. And later on, when they became available, we tried to do as much on technology, digital technology. We were able to talk to patients, but we really couldn't do a colonoscopy, we couldn't do a pap smear, we couldn't do a breast exam. And this led to massive delays in diagnosis. And
so it fell down the priority list massively, substantially.
Yes, exactly.
Okay, well, Sanjeev, we're going to come back to you in a second as well, so stand by, please, because we will have more questions. I know from our audience they're coming in thick and fast, I can see in front of me. But now I'd like to bring in Dr. François Uwinkindi. Dr. Uwinkindi, welcome. Thank you for joining us at the World Cancer Leaders Summit. Rwanda has been moving towards digital innovation in cancer care as well. Can you talk us through this process, what has been implemented, and also the challenges that the Rwandan Ministry of Health is facing?
Thank you so much. I think Rwanda, it is the same for other low and middle-income countries. We are still struggling to have comprehensive cancer services under one roof. Patients are obliged to navigate across different facilities looking for care. So I can take surgery from facility A, go to facility B for the radiation therapy, and then come back maybe to another facility for chemotherapy. And then patients are being lost, in between, and we are not able, patients are not able to finish their treatment plan. So with these digital solutions that are now available on the market, we are creating a virtual comprehensive cancer center for the country, using these digital technologies to link different cancer centers in the country, so that all the clinicians treating patients can talk to each other, can discuss and have one treatment plan for our cancer patients, and then be able even to follow up the movements of patients. Because clinicians will be able to connect and talk. Clinicians will be able to teach each other, and the clinicians will even, through these digital solutions, have access to national treatment protocols, and they'll be able to treat patients the same way. And we think with these digital solutions, we will be able to improve the survival rate of our cancer patients, but also be able to minimize the loss follow-up as patients are still moving across different facilities, seeking for care, and then clinicians are not able to talk to each other.
I'm wondering what success you've been able to measure so far then with this digital innovation. How have you seen that actually perhaps improve cancer survival rates, or certainly improve cancer care?
Yeah, I think the improvement of cancer survival rate is like an outcome that we are expecting. Maybe after 2 or 3 years, and even 5 years. But now there are maybe immediate, gains that we are now seeing. So first, clinicians are now able to talk to each other and discuss and agree on a treatment plan for patients. So now we are focusing on patients, not really focusing on services available at each and every cancer center. Now we are seeing that now clinicians are treating patients according to the national guidelines and protocols, because these protocols are available in the digital platform, and then clinicians are discussing and agree on the treatment plan. And we are also seeing the reduction of loss follow-up of patients, because now with this digital solution, patients are facilitated to move across different facilities. And once a patient reaches to the facility where she or has been referred to, he's or she's a patient that is being weighted, and then the clinician can be able to continue from what has been done at facility A. And at the end, we will be able to reduce even the cost of treatment, because clinicians, we are no longer, repeating the tests that have been done from the previous facility, because they can see now the tests, CT scans, MRIs, lab tests in the platform, and be able to take it from there and continue providing the care as it has been planned during the treatment plan. Yeah. So, and we think these are really gains that we are seeing, and we think at the end, we will be able now to improve the survival of our cancer patients.
And François, how do you manage patient confidentiality and privacy in this new technology, new digital world?
Mm-hmm. And first of all, data are stored locally. So we are storing data on the Ministry of Health servers. So data is not stored outside the country. And second, these are protected platforms. You know, all clinicians that are using the platform have got credentials, have got, they are login credentials, and then no one who is outside the care, outside of those clinicians that are taking care of patients cannot have access to the information that you have in the platform. And also this platform, in order to, to reduce the work of our clinicians, is connected to the existing electronic medical record systems from different facilities. So, and we think with that, and again, the administrator is also from the Ministry of Health. We can be able to monitor who is using the platform, who is, which information is being entered and which information even is being downloaded. And then, so these are measures that are really helping us to protect the privacy of our cancer patients.
Does each country and any country need to have a specific health infrastructure in place in order to bring in and adapt to these new digital technologies? What kind of investment is needed just in the broad infrastructure in order to really realise the potential of digital technology?
Yeah, with our experience, we have realized that at the beginning, the cost might be high, but at the long run, the cost is not really high, because maybe what is needed to invest in is the hardware to make sure that computers are available, laptops, maybe tablets, these are things that are really, the capital investment, and these are things that will last for a long time. And second, you should have internet connectivity, because these digital platforms, we know that they can work offline, but if you need to share data with other clinicians in the network, you need to be connected. This is also another investment. And again, we need also to be able to train the users, make sure that the tool is used appropriately. These are also some of the investments that have to be done, but also doing it. So we are working with different partners that are supporting us, but at the end of the day, the country has to sustain it, to own it, so that we can be able to use it for a long time without even having that support of these partners that are supporting in this journey. So these are maybe the key investments that we can, talk about now.
Yeah, fascinating. And I'm sure we'll have more questions from the audience as well. François, Dr. Uwinkindi, many thanks. We've had some great interaction on the Summit platform during this session, and we're now going to take some of the questions that you've posted, the questions that have gathered the most votes as well. So the three panellists are still joining me. Welcome back to all of you. Let's go to the first question, and perhaps we'll do this to David. How do you ensure international standardization and interoperability of digital health solutions?
No, that's a fantastic question. I think there's several different aspects to that. To the extent that artificial intelligence is trained, which in our case is on tens of thousands of patient images, it's trained using localized data. There's always a risk that it won't generalize. And I think it's very important during the training and validation of all digital pathology and artificial intelligence platforms that you have access to material from broadly distributed sources. Just for instance, in a recently approved algorithm that Paige developed, there were 800 different institutions from around the world in the validation set to ensure that there was generalizability. There's also issues with, how do you deal with patient data? This was just discussed a minute ago, and enable people to use the tools in an international environment. Much of this is moving into the cloud, and I think that will be the solution to deal with large data applications and to ensure that a single system is able to manage all of them.
Okay, great. Now a question to Sanjeev. Let's come to you. And François touched on this a bit in his opening comments there. But how do we ensure technical reliability of digital health platforms? Dr. Arora, to you.
Yeah, I think that certainly the kinds of things we're talking about, using artificial intelligence and data interoperability and getting insights that can change the world, will make a huge difference to the world. And at this time, as you heard, there's a fair amount of infrastructure to be laid down. On the other hand, and that should be done, and I hope we're on our way to produce more equity. But today, because of the pandemic, the vast majority of the world has connected on some kind of video conferencing, even in Africa, rural India, Bangladesh. People are able to connect to the internet, join Zoom sessions on, especially most of the healthcare providers have enough internet connectivity right now to at least participate in an echo session. So the technology required to participate in echo is actually freely available currently to healthcare providers all over the world. So what really is missing here is our will and desire to democratize expert knowledge. If we use existing technologies and take experts, global experts who are willing to share their knowledge with others, not on a webinar format, but in what we call case-based learning or iterative guided practice, like I was talking about, spending a small part of their day, 1 to 2 hours a week, to mentor other healthcare providers to become as good as them. We call that force multiplication. What will happen is we can use existing technology to produce a lot of equity. Equity is not the same as standardization, in my view, because as I was giving you the example of the person with breast cancer in Africa, they may not have an MRI scan in that particular location in Africa. Could be a small village, small town. We have to adapt. So I think the combination of using human interaction, communities of practice, which work with empathy and kindness and respect, we can produce equity without the necessity to produce equality right away. Equality is definitely the goal, but that could take a little bit of time. And I'm saying that sharing money, sharing resources is actually a zero-sum game, because, in the United States, we give away half our money, we are left with only half, right? But sharing knowledge actually can be generative, especially if you do it in a way where we do use case-based learning and all teach and all learn. You can create new knowledge and everybody could become the richer for it. So what we really need is experts who are willing to share for the purpose of making the world a better place. And many, many cancer experts and our partners all over the world. You heard from ICCP and how they use ECHO, MD Anderson and National Cancer Institute and Dana-Farber Cancer Institute, and many, many other cancer partners have chosen to do that. And I invite all your experts all over the world that are joining the session today to reach out to me, and we will help them if they have an interest in democratizing their knowledge with the necessary technologies, build a platform so they can have greater impact to reduce disparities all over the world.
Thank you very much. Dr. Uwinkindi, a question for you from our audience. Do you see the digital solutions approach in Rwanda as a national approach? Is it linked to the National Cancer Control Plan of Rwanda?
Definitely, yes. Because, and we have seen it even during this COVID-19 pandemic, because without digital solutions or platforms, now it's becoming impossible even to, as we also do some teleconsultations, be able even to consult patients from where they are living. So, and if you look at our cancer control plan, digital use of these emerging digital solutions, and I had also, the representative from Paige talking about artificial intelligence. So we are also in that field, see how we can now, because we have an ambitious plan to eliminate cervical cancer in Rwanda. So to be aligned with this WHO new strategy for global cervical cancer elimination. So we are now also, piloting some artificial intelligence applications to be able now to do the cervical cancer screening. So, okay. And then if you look at what we have in our cancer control plan, so digital solutions, digital platforms have got really, a big role to play to be able to deliver cancer services to our people in need.
I see. Okay. We have time, I think, just for one more question, and I'm going to come to you, David Klimstra. So the question from the audience is, can digital health solve some of our pressing challenges, such as access to medicines, especially supply chain issues?
I think what it can do is enable us to pinpoint what medicines are needed. And we've had some discussion about this already. In every environment today, there may not be the same access to the same testing or to the same medications. But by using artificial intelligence, we are able to pinpoint what agents are most effective. There's the potential to replicate genomic testing to identify susceptibility of cancers to certain agents. And, through the collaborative efforts that we've been hearing about, to tailor the treatment ideally to the patient. And I think, this is the next horizon, that we're able to infer information from existing technologies using digital assistance. In terms of supply chains, I think that, this is an international problem that digital health can bring together people to help solve. I don't have an answer from an AI perspective to that solution, but I do think it's possible to democratize access by understanding what the ideal treatment is through a variety of digital health initiatives.
Okay, well, thank you so much to all three of our panelists, to David Klimstra, to Sanjeev, Arora, and also to François Uwinkindi. It's been fascinating to hear from all three of you gentlemen, and we appreciate you sparing the time to talk to us and all of our participants today. Thank you very much indeed. Now
you,
to
Hannah.
our audience, bye-bye everyone, to our audience, we are going to take a break for 10-15 minutes or so. We'll see you back here at 1 o'clock Boston time, that is 7 p.m. in Geneva, in time for our next conversation, this time bringing patient perspectives into the discussion. So as I said, about 15 minutes from now. See you then.